Yeah, I definitely see some more people joining, so we'll just wait maybe 1 or 2 more minutes and then we'll go ahead and start.
Okay, everyone, I think we're ready to go ahead and get started. My name is Alexandria, and thank you so much for joining us this afternoon for our conversation, Creating Space for Interdisciplinary Thinking and Doing. So today we're going to start off with some introductions of the moderators, the speakers, and our sponsoring organizations. This afternoon, we will hear from 4 amazing women who all share this common goal of empowering women. We'll close with some time for questions from the audience. And so as we're going through this conversation, we're going to keep everyone on mute until we get to the Q&A portion. Please feel free to keep your cameras on if that's something that you like to do, and you're always welcome to communicate with each other in the chat. We'll also be recording this conversation so that we can send it out to collaborators and other people who are not able to join us today.
So I'm Ashley Deans. I'm going to introduce our moderators, one of which, of course, is me. I am the communications specialist at the Center for Global Women's Health Technologies, or GWHT, you might hear us call it. And I will be co-moderating the speaker sessions and the live Q&A with my colleague, Alexandria DuPont, who you just heard from. She is the Associate Director of Operations at GWHT, and we are joined by Andrea Kim, Director and producer of the Invisible Organ documentary, who will be moderating the panel session.
Are going to be hearing from 4 different speakers, as I mentioned before. We have with us this afternoon Dr. Nimi Ramanujam. Nimi is the Center Director for Global Women's Health Technologies at Duke University.
Oh, I am so sorry.
And Nimi is the founder of the center, is what I was just saying. She founded the center in 2013, where she empowers trainees to create impactful solutions to improve the lives of women and girls locally and globally. Sitting by the fire at her house right now, we are joined by Dr. Wesley Hogan. Dr. Hogan is the current director of the Center for Documentary Studies at Duke University and a research professor at the Franklin Humanities Institute and Department of History. Dr. Hogan writes and teaches the history of youth, social movements, human rights, documentary, and oral history. Our next speaker coming to us today is Dr. Geeta Suneja. Dr. Geeta is the Associate Professor of Radiation Oncology at the University of Utah School of Medicine. She also has an appointment within the Department of Population Health Sciences. Her clinical specialties include the treatment of breast and gynecological cancer, and her research program focuses on utilizing advanced health services and research methods to enhance health equity and cancer outcomes. Dr. Mercy Aseyedu graduated from our center with her PhD in biomedical engineering, where she worked on developing the Calliscope and the pocket colposcope technologies. Mercy is currently a postdoc at MIT in Computer Science and Artificial Intelligence Lab. Thank you to all of our panelists for joining us this afternoon.
Thanks. So I'm just really quickly going to take a minute to recognize and introduce the organizations that are sponsoring this event, starting with GWHT, the Center for Global Women's Health Technologies. We are a research lab at Duke University that aspires to make cancer diagnosis, prevention, and treatment more accessible and more effective for women worldwide. This center, since inception, has catalyzed new research activities and the development and commercialization of several technologies that advance prevention and treatment of cervical and breast cancer by placing women at the center of healthcare solutions. We leverage technology to create sustainable ecosystems of change. I also want to introduce the Calla campaign. The Calla campaign began in 2018 as an artistic campaign aimed at reducing the shame and stigma associated with women's sexual and reproductive health through creative expression. GWHT hosted and curated an exhibit for the campaign titled The Invisible Organ, which was held at the Rubenstein Arts Center at Duke University in the spring of 2019. The goal of these projects and grassroots types of community engagement are to abolish the otherness associated with women and women's health. And then lastly, of course, The Invisible Organ. This documentary, produced by Andrea Kim, is the culmination of a 2-year project started at the Center for Global Women's Health Technologies through the Calla campaign. So with that, I'm going to pass things off to Andrea, the director of the film, to briefly give a little more information about the film that inspired our discussion today.
Thank you so much, Ashley. Yeah, so The Invisible Organ, it's a 50-minute documentary. We screened it 2 weeks ago as part of kind of Cervical Cancer Awareness Month, and it's available online to watch. Basically, for those who haven't watched it, it follows the story of the Callascope and how it reinvents the gynecological exam by allowing women to see their own cervix without the use of a speculum. It also is about how gender-based stigmas and disciplinary silos can play a role in impeding women-centric and community-centric innovation, which is really what inspired today's panel. How can we create more cultures of inclusion and dialogue when it comes to reproductive health? And how can we reframe our approaches to medicine and global health? So in this panel, we want to get more into the nitty-gritty of that whole process. Part of it is captured in the film, and we're opening up this space to continue that dialogue and get some questions from people who watched the film or are here to learn more. But yeah, we just want to kind of talk more about how interdisciplinary this collaboration was grounded in this passion for gender-based barriers to health. So,
yeah, with that, we're just going to pass it over to our first speaker. And I'm going to stop screen sharing, and I recommend for this portion, while our speakers are talking, you go ahead and switch your Zoom over to speaker view, just so you can go ahead and focus on the person who will be sharing with us. So first, I'm going to pass it off to Dr. Ita. Thank you.
Great, thank you so much. It's so wonderful to be with all of you today. I'm so happy to see my friends and collaborators who I haven't seen in a very long time. So this is a really great opportunity for us to connect to. So I don't want to take too long because I want to make sure we have lots of time for questions from people who have attended. But I thought maybe I'd talk to you a little bit about my background and kind of how I ended up involved in this project. And then also tell you a little bit about my kind of experience being a part of it. And then also just the sort of management of cervical cancer in general, because I know the film really focused on reducing the impact, the negative impact of cervical cancer. And so I thought I'd just highlight that as well. So I am, as Alexandria pointed out, I'm a radiation oncologist, and I'm currently in practice at the University of Utah. I love, love, love what I do because I get to teach students and residents, and I also have a clinical practice treating women who have breast or GYN cancers. So cervical cancer is one of the things that I specialize in. And then I also do a lot of research. In fact, I spend most of my time doing research, and that's really centered around health equity. So who is it that gets access to cancer care? Or in my case, I focus really on who doesn't have access to care, and why do they not have access to care? And similarly, we look at differences in outcomes. So we know, for example, that Black women have worse outcomes from cancer than white women. And so we're trying to understand, a lot of my research program is focusing on trying to understand why that is and how we can improve those outcomes. A big focus area for me has been on patients who have both HIV and cancer. And I think that interest has really come out of treating patients with cancers, especially GYN cancers, in other parts of the world. So I'm part of a large research program in sub-Saharan Africa, and what we see there is HIV rates along the lines of 25%. So a lot of women who come in with cervical cancer also have HIV, and there's some unique issues in terms of treatment that I've spent a lot of my research career focusing on. So really HIV malignancies, and then also delivering cancer care in global low resource settings are two areas I'm really passionate about. So I think, part of the reason why this project spoke so much to me is that I grew up with one parent who was a scientist and one parent who was an artist. And so I had these kind of two parts of my brain that were really nurtured, and I just have a really profound appreciation for both things. And I spent a lot of my undergraduate and graduate work trying to figure out, how do I marry these interests? And when I was an undergrad, for example, I studied math, but then I also studied sociology. And it was one of the things that got me really interested in social determinants of health. These things outside of the clinic, like education, income, transportation, things that really affect outcomes for the patients we see and treat, but that are often not really addressed or discussed anywhere in a clinical encounter, and are often not really taught in the medical school curriculum. So I was really interested in that. I went to Brown for medical school, Brown University, where there was a big emphasis on social justice in healthcare, on global health. And I started to, as I got more kind of involved with people who were doing that type of work, I started to really see how the pieces could come together for me, focusing on a career in medicine, in oncology specifically, but also bringing in these other things I was really interested in, like global health and health equity. So I did my residency training at the University of Pennsylvania, and that's where I really had the opportunity to do kind of more substantive work in the global oncology realm. That's where Penn had a large program in primary care in Botswana. And that's where I really got my start in doing global oncology and global radiation oncology. And then the last thing I did when I was a resident trainee that I think was really helpful and kind of helped shape my career was I did a master's degree in health policy research. And what I learned from that is it's one thing to do research and to put it out there in the world. We write these manuscripts and they're reviewed by our peers and they get published in the literature, and it's also read by our peers. But does that really do anything for patients? Does it change anything for patients to just show that there are these differences in access to care and outcomes? And what I learned and what I've really focused on a lot is taking that research and turning it into advocacy. So how do we actually advocate for this patient population, move the needle forward, and start to really change how this care is delivered? And so I was thrilled when NIMI approached me about this campaign and this project to participate. For me, it really married my interests in science and research, global health, art, communication, all these things I was really passionate about. It sort of unified all of those. And I also thought the work that had already been done on developing what I at the time viewed as kind of a medical device, it was so remarkable and so inspiring to be able to have a device that was much more streamlined than the classic speculum that we had been using for so many years. I think what I learned from this project and from all the collaborators who are on today is that this really took that continuum of research and advocacy a step further to empowerment. So it's one thing to advocate for the population of people that you're interested in or study or work with or treat, but it's a totally different level to actually give them the power to advocate for themselves. And I I just found that so so remarkable and so wonderful, and it changed my view of this device. It's, instead of thinking of it as a medical device, really thinking of it as a way for people to gain empowerment, knowledge, and really art, which is kind of, you know, what this all culminated in this documentary. So I think, let's see, I've been talking for several minutes now. I can either talk a little bit about cervical cancer, or we can come back and do that after everyone's introduced themselves, or if there's more questions about it.
You can go ahead and just talk very briefly about cervical cancer, and then we can come back.
Okay, sure.
Questions.
Sure, absolutely. So cervical cancer is kind of an interesting disease. Basically, there's an orderly progression of cells in the cervix that start to become abnormal over time. And it's actually a really well-defined process from abnormal cells to cancer. And the beauty of that is it gives us an opportunity to intervene before cells become cancerous and before the cancer spread from the cervix to other parts of the body. And so that's why you see a lot of public health messaging about getting pap smears, GYN exams, and now, you know, recently, and when I say recently, like last 10 years, the HPV vaccine, which actually prevents the development of cancer and helps the body clear these abnormal cells. So it's an uncommon cancer type in that we really have a great idea of how it goes from abnormal cell to cancer, with multiple opportunities to intervene and kind of stop that process from taking place. But it is a fairly common cancer type, especially in global settings. And it disproportionately affects young women. And the reason that that's so important is that there's enormous cost, both personally to these women who are affected and their families, but also to society. When women who would otherwise be working inside or outside the home are really taken out of that workforce because of illness or death. And so it's huge cost to society. Early stages of cervical cancer are treated primarily with surgery, and then more advanced stages are treated with chemotherapy and radiation, which is a lot of what I focus on. So as far as cervical cancer goes, prevention is the #1 best thing we can do. And then we also are working on making our treatments more tolerable so that women who do undergo treatment also have better outcomes.
Thank you so much for sharing with us. We're going to go ahead and move on to Dr. Mercy Aseedu to share with us.
Hi, thanks again for having me. So I guess I'll just give a bit of background on myself and how I joined the project. And so if you watch the documentary, you already know quite a bit of my journey towards the project, but I came from Ghana and went to go a scholarship to the University of Rochester, where I studied biomedical engineering. And before that, I always thought I'd go into medical school. And my kind of passion there was really to help improve maternal health outcomes by perhaps becoming a gynecologist or an obstetrician and gynecologist. And I was going to go to medical school in Ghana before I got a scholarship to the University of Rochester in New York. And since the United States doesn't have a direct medical school program, I decided to do biomedical engineering as a pre-med offer. But during that time, I kind of really learned more about biomedical engineering and tools and ways in which technology could really help improve health outcomes. And I really found that fascinating. So I changed my mind and decided to do a PhD in biomedical engineering instead, and focus on global health applications. And interestingly enough, at that time, it was really difficult to find a lab where the PI was doing both biomedical engineering for global health. And I was lucky enough to come across Dr. Ramanujam's page on Duke and reached out to her, told her I was interested in the work she was doing, which was on cervical cancer, using technology to reduce cervical cancer and breast cancer disparities. So I applied to Duke after my degree, came here and, came to Duke, joined the Center for Global Women's Health Technologies, and started working on the project on cervical cancer, which really had more of a focus on reducing health disparities. And I worked then with a grad student who was already working on the pocket colposcope, Christopher Lam. And while we were doing that, the need for, the pocket colposcope was being developed, which was a smaller insertable version of a colposcope, but there was still the need for expanding vaginal walls, because you can't just insert a camera because the vaginal walls just close in. So there was still kind of a need for a speculum-like device that could expand the vaginal walls to see the cervix, but wouldn't be as uncomfortable. And that was really what I got involved in and spent some time working on. But in terms of I don't know, should I go more into that, or should I talk more about the Calla campaign now? What do you guys want me to do?
Feel free to talk about the Calla campaign as well.
Okay. So the Calla campaign, with the Callascope and the pocket colposcope, we, did a lot of in-lab testing and clinical testing. There was a lot of kind of, the very research-based aspect of it, where we are trying to figure out what kind of models work best using computational simulations, and also trying to figure out how to best test our device outside of a human. So coming up with a phantom that was like a cervix, or that kind of mimicked the vaginal canal and the cervix, was one of the big hurdles we had to cross, and then figuring out which type of designs we had could withstand the vaginal walls and center the cervix. So after some clinical studies that we had done, and those clinical studies actually showed that the Callascope could be used to see the cervix, which was really surprising to us. I guess not surprising, that's what we wanted it to do. But, like throughout the journey, in terms of asking people for advice and things like that, it seemed like it might be an impossible kind of constraint, like to get women to do this themselves, and to insert it and view their cervix themselves. So during our first clinical study, which was done at the Duke University Medical Center, it was kind of a combined approach between self-use and having a provider help if the patient wasn't able to see the cervix. So that was where we really had people use it, and then a provider guide them to insert it and to kind of find where their cervix was, with very little pre-existing knowledge on how their cervix looked like. And I guess that's where the surprise came in, because almost, I believe like almost everyone was able to see their cervix with provider guidance, and significantly preferred using the Callascope over the speculum. So that was really encouraging results. And kind of from there, Nimi and I and Wesley had also discussed I guess Wesley and Nimi had discussed making it into an art campaign first, but I was also very interested in that because during one of the conferences I attended, which was the Consortium for Universities of Global Health, they have this section where they show a video. They have a Pulitzer video competition, and people show documentaries that kind of raise awareness for different global health problems. And I thought it was just a really amazing way to draw more awareness to global health disparities. And I had spoken to Nimi a bit too about that, about potentially having us have a similar kind of documentary around cervical cancer and around Calla scope. So I thought the arts campaign would be really fun and a good way to kind of get it out of just being a medical device and more of an awareness and advocacy or self-advocacy tool. And from there, we went down this line really of trying to combine our research work and engineering and clinical work with art and self-reflection and, what women or the users thought when they used it. And it was very interesting combining those two trains of thought and having weekly meetings with people like from different disciplines than I was used to, and really learning what it took to bridge the art world and with the science and engineering world was really cool. So yeah, that's how I got involved. We came up with studies to for women to use the device this time on their own, completely without any assistance from a provider, and to share reflections on how they felt when they used the device. So we were collecting both data for scientific research, but also collecting data for the arts campaign at the same time. And from there, those results were provided to artists who turned it into a beautiful art exhibit. So, yeah.
Thank you so much for sharing that. That was wonderful. I'm now going to pass it over to Dr. Wesley Hogan from her fireplace.
Hi, everybody. It's such a pleasure and joy to be with everyone today, and especially with my colleagues. So I haven't seen Geeta and Mercy for so long. So such a happy day to see you guys. So I got involved because, I'm just drawn to interesting people who have great energy because I learned so much from them. And so in 2013, somebody at Duke pulled together like 8 faculty from across different parts of the university, and we had to do this thing once a month. We get together for dinner, and we were kind of learning a different set of skills all during that year. And the person who I enjoyed working the most with that year was Nimi. And so from 2013 on, we just kept pitching each other projects where like biomedical engineering and doc studies could overlap, but we came up blank. We tried a bunch of stuff and not much stuck. And then in December 2016, we went to dinner, and Nimi told me the story, which was so captivating, about what Mercy was working on. And she said she's, this amazing device. We think it could virtually end cervical cancer, but it doesn't matter if women don't adopt it. And I was like, what's the problem? Why aren't they adopting it? And she said, well, we all have too much shame and stigma about our vaginas and our cervices. And Nimi, she's like really excited, and she was excited, and there were people in the restaurant, and I realized that I had the same damn problem because I immediately felt shame and stigma because she said vagina and cervices at room tone of voice, right? And I was like, like that. I'm like, what is wrong with me? I've had 2 children, it really brought me up short. And so I immediately realized how accurate she was from my own immediate shame. Here I was, considered myself a womanist, a feminist, and had read Our Bodies, Ourselves in several editions. And yet I had never seen my own cervix. Nimi had an iPad there, and I was looking at the cervices she was showing me, and I didn't know what I was looking at. And so I was totally hooked. It was the best storytelling hook. Nimi will constantly say she's not a good storyteller, and I'm just calling BS on that because that was such a good hook. So it made me realize something was there with somebody I really enjoyed working with, and I'm, super interested intellectually. So my part was to work on the storytelling hooks that would allow women to put their shame aside long enough to come to the table and try out this medical device. And so we tried that here in Durham, and then we started designing different storytelling approaches that were appropriate for each community in which teams would work. So in the US and other parts of the world. So In the Q&A, we can talk more about that, sort of how that part continued to develop, the storytelling part. But part of what I wanted to also talk about today was just the 2 Basque Connections classes that we developed as a result of the work. So in 2019 and 2020, we taught our first class with Duke undergraduates and graduate students, which was really important and helped us develop this framework a lot better. How do you integrate these very different disciplines of storytelling or doc studies, technology, and visual art? So that was the class in 1920. Undergirding all of those, bringing those disciplines together was a really strong ethical core. As Andrea mentioned, in February 2019, we did an art exhibit in the Rubenstein. And while it was beautiful and captivating and really exciting, I had a lot of familiarity with the art world, and we made a lot of mistakes in terms of our ethics and how we brought in artists in the community. So there was a really big disconnect with how Duke on its science side handles researchers coming in, and how Duke on its art side brings artists in. And we hadn't thought through all the way how to integrate those 2 kinds of visitors. And we hadn't made enough time to work through all of that. We were working on a very short timeline. And people got hurt. And so we didn't want to do that again. And so part of the Basque class, we also looked at how can we do this better going forward to truly integrate what Gita talked about. How do we bring together science and art in a much more deeply humane and compassionate way so that those folks can learn from each other and not feel exploited? So we did a lot of that work in class of developing an ethical framework. We read things like Toni Cade Bambara's The Salt Eaters. Nimi grounded us in the work her group had been doing. We read a lot of history of gynecology, and we used a participatory research framework. And the project team created a platform through which we could really shift the narratives of shame and invisibility that surround the female reproductive anatomy. We also talked a lot about, should we use the term woman and girls, or should we use the term people with cervices, since a lot of trans men still have their cervix. And so we got deep into the issues around language and justice. And finally, we realized you can't really start a conversation with somebody you don't know by just asking people, like right off the bat when they come into a community workshop. You can't say, okay, everybody write down, if your cervix could talk, what stories would it tell? Like, nobody who comes into a room right away is just going to start talking, right? So our students developed these incredible ways in that spring semester through theater of the oppressed, through expressive writing, through visual art, poetry, short films. 2 people did a great interactive video campaign on medical racism that they're experiencing now and that they shared with others. We had a PhD in musical composition who developed a beautiful piece of music for how we could invite people in a much more inviting way and kind of build a community workshop space in all of these different artistic forms to get people to talk to each other and build a community with several earlier prompts, and then get them to say, answer a prompt like, if your cervix could tell a story, what stories would it tell? And those students developed some really empowering techniques to support that participatory research framework. And then Ashley, I need you to go. Am I over time? Do I have time to talk about the second Basque class or no? I can totally wait for the Q&A.
Yeah, maybe just give us like 2 sentences and then we can come back to it.
So this year, we're doing a second Basque class. It's called Empowering Prevention of Cervical Cancer, Women-Inspired Strategies for Health, or WISH. And we are reframing a lot of stories. So the non-consensual origins of gynecology, we're really focused on centering those most impacted by cervical cancer in Cajamarca, Peru, which is, we're working with Dr. Patty Garcia in Peru. And so we've learned about the historical and cultural background in Cajamarca.
Thank you so much, Dr. Hogan. So we are going to hear from our final speaker today, Dr. Nimi Ramanujan, to share her thoughts.
Thanks, Alexandria. I'm struggling to figure out what more I can add to the beautiful thoughts and perspectives we have just heard. So I'm going to speak a little bit about the genesis of the Center for Global Women's Health Technologies. I went to give a seminar at Smith. It's a college right out of in the Northeast, and it's a college, a women's college, and when I gave a talk there and saw a room full of female students who were able to just freely express their thoughts and ask questions, and I incidentally, happened to speak about the Calla scope, I thought, how can I create that at Duke? I think I taught very few classes where the majority was female. In fact, no classes. I just made that up, 0. So I created a course called Global Women's Health and Technologies as a way to draw in more students, more female students. And it was a little bit of a trick, right? You put the women's technologies in there, and that garners a lot of interest. So, and then I thought, I have been doing women's health research my entire career. Why don't I create a center around that? Because if there are women's problems that entail the use of engineering tools, what a great way to draw more female students into quote unquote STEM education, not to make it so dry, but make STEM secondary and make women's health the real center of the narrative and the project. Long story short, I realized that indeed was a hook. I mean, students really enjoyed being able to work on things that they could relate to, that they had personal connections with. And it was something that I had hoped for when I was studying engineering, which is to connect the humanities, the social dimensions, the learning about people, and then trying to design tools that help them, rather than designing the tools and then figuring out how engineering could be applied to, women writ large. So a number of programs respond around that. And I'm a musician, and I found engineering a little bit dry when I was in college. And for me, it was so important to bring my musical senses to engineering. And I thought about how music is pervasive. You can go anywhere in the world and music is everywhere. And why isn't engineering everywhere? And how can you make engineering like music? How can you make it not so specialized, but actually something that people can relate to and not be intimidated by? And so in digging into the humanities, then I realized that the center is not limited to engineering students. And lo and behold, students from comparative studies, literature, anthropology started to be interested in the technologies we were developing. And the Calla scope was a great way to bring people in, because this idea of addressing a historical perspective on gynecology that had changed very little was very exciting from a historical perspective, from a technological perspective, from a women's health perspective. And then, of course, I'm not going to repeat what Wesley said. We have enjoyed many years of interacting. And when that opportunity came up, then artists started to join the group. And that's how Andrea came on board. And one thing I realized is I have to do very little work. Let me clarify, I do a lot of work, but I had to do very little work because students, when they're empowered, come up with the most imaginative ideas, and to set them free to act on them really pays dividends. And that's what I noticed with art, with technology, with the social dimensions of women's health. I had students from all over Duke come and work together, sort of creating this interdisciplinary space in a very natural, organic way, not forced, but brought together by a common cause. So what was happening at the top was also happening all across, laterally and vertically. And that to me was really, really exciting, that you can create an ecosystem where this happens naturally. So when the idea of an art exhibit came about, and Wesley and I talked about it, we wrote this little grant for $3,000, and I was terrified because I didn't know what to write. And so Wesley helped me sort of bring that all together, as did Geeta. And then we had this art exhibit. And then we've just moved on since then, because the idea that you take the first step, no matter how scared you are, allows you to then work up to a marathon. And so that's really what has happened. We're looking at this as in the long term. How can we use this platform to really not only engage communities, but how can we actually bring technology into that picture, something that can be a really important tool in actually changing the narrative in a positive way about a disease and an organ that is indeed very invisible. So I just wanted to add those elements to what we've already heard. So just want to end there.
Thank you so much. That was really great. And it's always so good to hear from you. So we've concluded our speaker sessions, and we're going to move into our panel session, which will come right before our live Q&A. So Andrea, the director of the documentary, is going to be moderating this section, and she has some questions from our panelists that we will all get the benefit of hearing their answers to. So I'm going to pass it off to Andrea, pull up our PowerPoint again, and we can go ahead and get started with the panel.
Thank you so much, Ashley. Yeah, so a bit of framing for this panel discussion segment. So 2 years ago, when I was a post-baccalaureate fellow at the lab, at Mimi's lab, Global Women's Health Technologies, I made a lot of science communication videos on behalf of the lab. So that entailed talking with biomedical engineers about their research and like trying to parse through that language into a video format that viewers could digest. And a lot of these same methods were used for the documentary. And I think like what's learned from that process, at least from my end and in my field of, media studies, science communications, or like the anthropology of science and things like this is really the depths of disciplinary difference, not only like within like the different specialists, but also with a project as expansive as the Calla project, involving nurses, health advocates, physicians, patients, a lot of different people. It's really challenging, even at the level of building trust and explaining to each other what it is that we do or why we're doing it. So I wanted to kind of acknowledge the difficulty in taking that step of changing systems which already are in place, and the burdens that come with that, and the new methodologies, the new structures that we kind of have to build from that. So that kind of draws me to my first question I'd like to present, which is, how do new methodologies emerge from interdisciplinary collaborations? To kind of kick off this question, I'd like to ask Nimi, who spoke briefly about, how the lab began, but Nimi, when you first started the lab, Global Women's Health Technologies, almost a decade ago, not many people at Duke were blending global health concerns with biomedical engineering. And so in the film, you mentioned sometimes engineers can get lost in their own design process. Could you speak a little bit more about what you meant by this and kind of that process of bringing those two disciplines together?
Yeah, at the core, I will say, and I'm guilty of this, which is we all feel comfortable in our own domains. I mean, it's like speaking a new language. It's hard to learn a new language, and we're comfortable speaking what we know. And I had an experience where our first project on cervical cancer prevention was in Haiti right after the earthquake. And my student had built this very elaborate device that is, quite good in terms of detecting cervical precancer, but it's vastly different from what is, practical, and it came with all these little, components that were very sensitive to the environment. And when he went there, everything failed. Everything failed. So this was an example of where we thought we knew best, and we forgot to include the stakeholders for whom this really mattered. And I think that was sort of the aha moment for me, which was, gosh, we have all this grant funding for this particular technology. We've got to make it work to, you know what, in the long term, not doing it right is going to cost a lot more. And so I think that was the pivot for me. And I think it's really hard. And in my school of engineering, we really talk very little about that dimension. I think it's becoming more pervasive, but at the time that I was thinking about this, it wasn't so. And I think that's what really made me think of this center, is that Duke is a very special place. It's small, but yet it's vast in its intellectual landscape. There's so many different disciplines. And since it's small and there are not that many people overall, it's easy to make connections. And I thought, what better place to do this than Duke? Because you have a very strong humanities dimension as well as engineering and the sciences. And so to me, it was very natural to coalesce all these disciplines into one place. And so that's really how it started. And as far as methods, I would say we're constantly evolving. And I think that something that's really important is, whether you're working with patients or students or collaborators, I think you have to be really open-minded to new ways of learning and integrating that into your life. And when you do so, I think that diversity in thinking and approaches really enriches the work environment and the products that result from it.
Thank you so much. And I'd like to pass this question to Wesley. And your background of oral history, could you speak a bit to how the resonance between the Caloscope as the technology with oral history?
Yeah, I just want to build a little bit on what Nimi just said. Just watching her work too, in the way that she builds sort of a leadership pipeline and gives young people the ability to develop their own methodologies, rather than there are so many environments in which graduate students and undergraduates are sort of trained by doing it the way that the professor does it. And I really loved how, when I first came into her orbit, she was giving young people, whether they were graduate students or undergraduates, the ability to go on and do your thing, and I want to learn from you. So for a lot of people that can feel chaotic, that's the downside, right? But it's not chaotic. I saw the order in it, and I so appreciate the very many kinds of methods that it allows to flower, and the many different kinds of people it draws into the lab. So, and I felt really simpatico and at home, even though, there's been so many times when Marley or Yulia or Mercy or somebody had to explain something to me about engineering. So in terms of what I learned or how this impacted the oral history work, I think particularly seeing how the students in the first year's BAS class took oral history and developed artistic approaches to it was just such a delight for me. They came in because they wanted to build out the exhibit, and we thought that's what we were going to do in the BAS class. And because the exhibit, we hadn't sort of debriefed all the ways that hadn't gone exactly like we wanted it to. And so we ended up having to change the BAS class around a bit. And so what I learned so much from and built sort of new methods around that was really watching the students take. We had one student who was a first year student when she was in the class, and now as a sophomore, where she really wanted the LGBTQ community to be much more included in cervical cancer awareness, because oftentimes they're really overlooked, or they're alienated from the cervical cancer health public messaging because it's framed as sexual and reproductive health, and they're not thinking about reproductive health. And so they kind of tune out. And so she said, look, I really want to gear cervical cancer awareness to the LGBT community. And so I'm going to use this form of poetry. And she really worked on it all year long and came up with this beautiful workshop, and had us participate and like sort of beta test the workshop during this full year. And at first I wasn't thinking about it as oral history at all. But the longer I sat in those workshops and like did the poetry, I was really thinking about it as an alternative form of oral history. So I don't know, I learned so much about different approaches to people telling their story. It's not just sitting there with an interviewer and talking. So I don't think I'm answering all the dimensions of your question, but that gives you kind of a sliver.
Yeah, and Andrea, I'll just add that I think there's new methods that emerge, but there's also new like deliverables or products, like in Nimi's world and Mercy's world, a technology or a device is sort of the end product of their work and their time. And in my world, a scientific manuscript or a patient's treatment plan. In your world, a documentary film. And I think what's really neat about this project is for a funding amount that is small compared to the types of grants that often people get to do work. There's so many different things that emerged from this collaboration. I think it's just really led to lots of different streams of thought and innovation. And I think that it's just certainly for each of us individually, I think we've learned new methods and new approaches, new ways of thinking about things. But I think it's also led to different ways to approach the problem in general, and different ways to get the messaging out that this is important and that we're not doing a good enough job on cervical cancer awareness and screening and treatment. And so I think that, hopefully that translates into more lives saved. But I think it's just couldn't be done without this sort of multi-dimensional thinking that comes from interdisciplinary work.
And I think for me, what really drew me to the project is the Callascope itself as a product, as the medical image, as the aesthetic potential of that image and the reaction it provokes to myself and other people who encounter it. So I think that's a really cool thing, and a core concept that I always come back to. The nature of the Callascope, the intimacy of the Callascope itself as a technology, I think is really provocative as well. In terms, for the interest of time, let's move on to the next question. It's what types of intentions were set in terms of making space for sharing and learning amongst each other in the Calla campaign?
Mercy, do you want to give that a shot?
Yeah, sure. So as soon as you said that, I think my mind went to Wesley's office. How relaxed she made us all feel as we were kind of talking, like everyone from different disciplines, with Gita and Megan Hatchko being OB guys, and then having Wesley, who was in the documentary office, and Fatih and Libby. And it was just the right setting to kind of get your mind in, like, at a place where you were willing to hear people from different disciplines, and it was just very relaxing, and we're able to share a lot. in that environment. So that was new and that was nice, a nice break from the offices we have, the more formal office meeting spaces we have, we are used to. But I think one of the, I guess one of the things that allowed me personally to make space for learning from different areas was just empathy and, you know, understanding where people are coming from. It kind of helped with that. For instance, I'd never really considered color scope use for transgender men, actually, until we started talking about the Calla campaign. And all this time, my personal focus was on women in underserved regions, and women who didn't really get access to care as much. So when I think someone brought up, I can't recall exactly who, but Wesley might have brought up the discussion about, you know, being careful about the kind of language we use, because transgender men also have cervixes and could also use the device. So not limiting the language to women really was a big learning experience, and actually even changed a paper I wrote on some of the more scientific outcomes of the color scope studies. So yeah.
I just want to quickly add on something you said earlier, Mercy, about Wesley's office, and it just and the kind of the culture to cultivate amongst each other. It kind of reminds me of, you know, when reading about feminist health movements from the 70s, both in like Los Angeles and Boston and beyond, focusing on kind of the intergenerational aspect and peer-to-peer learning that's not hierarchical, which I think Mimi has really internalized in her methodology with her students. And so I feel like we see these themes dating back to cultures of like midwifery and like DIY healthcare movements. And sometimes it seems like institutions and professionalism can be a barrier to that, of like being ourselves and sharing our own experiences and knowledge. I wonder, Geeta, would you say this, could you speak a bit to like the doctor-patient relationship and how you kind of navigate that boundary?
Yeah, I was just about to say, one of the things I loved most about the documentary was that one of the women interviewed was a patient of mine, and seeing her in her home, you know, with the things that she loved, you know, like seeing her seated in her chair with her blankets around her and the art she had on the walls and the plants she had, like it was so it just kind of rounded out a picture of her for me that you don't get in the clinic. You know, the clinic is a very sterile space. I mean, it's meant to be sterile, it's designed to be sterile. And it's I think you're absolutely right that, you know, the setting makes so much difference in terms of people's comfort level and also people's ability to share and to learn. And that goes both ways. That's, you know, for patients, but also for physicians. And I think that's something that we lack in our medical education, is really going beyond that clinic environment. And when I say environment, I mean the physical space, but also the questions we're taught to ask. You know, I've definitely seen, and maybe some of you have experienced, like a situation where you walk into a clinic room and it's like, there's no, you know, you just go straight to like what it is that brought you in today. There's no, you know, there's not necessarily that intentionality of getting to know each other first. And I think it's so important particularly for cancers that involve, you know, genitourinary organs, where people do bring some shame and stigma to the visits. It's so important to take that step back and see people's humanity. And I think that's challenging in the clinical setting, and something we really need to think more about how to make the spaces. Yes, they need to be, you know, they need to have certain standards for being clean and being able to be turned around for the next patient, but still be, you know, an environment where people feel comfortable.
I think that attitude is really embraced throughout, all the different spaces and people we interact with, like within the campaign, and it seems like a big value of it. Um, does anyone have anything to add with this question? I want to make sure there's some time for audience questions and um, maybe conclude with one other question on my end. Okay, so if we can go 2 slides forward to ask, how can the invisible organ expand our thinking about global reproductive health justice more broadly? So the film, focuses on preventative measures for cervical cancers, which is just one part of many different issues in this fabric of reproductive health inequity. So how might we kind of think about it, more broadly?
Maybe I'll start and I'll ask Nimi and Mercy and Geeta to jump in because I only know a small part of this, but particularly in the last 2 years, through the BAS Connections class, we've been looking at how can we develop a set of health equity practices that we can walk, not just talk. And how do we really center those most impacted by cervical cancer? Because the bottom line is that in a lot of global health programs and projects, the driver is people in power, whether that's people who give out the research dollars or people who are powerful politicians who allow or don't allow the projects to go forward. And so really thinking more deeply about if you're going to center those most impacted by the problem, in this case, the problem of cervical cancer, you have to really bend hard and sometimes break a lot of bureaucratic and policy procedures that are just sort of de rigueur in the US, in in Research One universities, and in many of the places where we might do this work. And that's really hard. That's really, really hard. So how do we develop a set of health equity practices we can walk, not just talk, I think is something that working with these amazing people on this project has challenged me to dig more deeply on.
Yeah, I think really all of medicine and the entire scientific enterprise is having this reckoning with social justice right now and racial equity. And, I think this year in particular has so greatly exacerbated inequities that were already there, that it's really brought to light how much work really truly needs to be done. And I think this year more than any, I say this year, 2020 more than any other year, people's feet have been put to the fire of not just issuing a statement or, but actually doing something real and substantive. And I feel like this whole project is sort of it's a platform to think about how to do that. And it isn't just, who are we doing this work for, but it's who is doing this work, who is funded, who are the scientists that are funded, are they appropriately representing the population that we're trying to address, who are the people actually conducting, these studies, is it like Nimi was saying, in the country, that where the relevant stakeholders are present. I think these are all questions that will improve global reproductive health justice when they are effectively answered, but we're all sort of reckoning with how to do this on a day-to-day basis in our own lives and communities, and then on an academic scale, and certainly from my perspective in the clinical realm as well.
So I guess I can add to that. So one of the interesting things that kept coming up when we're developing this technology was whether or not women could use it, or whether or not women could see their own services. And I think when we showed that we were able to test their Duke, and participants had been able to successfully use it to see their services, self-see their services. And we were writing some grants, and one of the reviewers was, yes, it worked here at Duke. How about, in African countries where you are going to deploy it, can women use it? And I honestly found that quite insulting, but it just goes to show kind of, what people, I guess, what people think women can do for themselves. In different scenarios and in different regions. And the interesting thing, and if you saw the documentary, you see that we actually did a study in Ghana, where we also did a self-study with people using the device for self-imaging, and it was just as successful as when we did it at Duke. And one of my concerns when we were going to do it in Ghana was actually more of a cultural association. Would people want to use it, given more conservative ideology? So it was really exciting to see both health providers really embrace new technology. On the high end, we had the director of the Greater Accra Regional Hospital who was really excited to have the technology there, and to nurses and midwives down to patients who were also excited to embrace a completely new technology just so they could just in a different way to own their own reproductive health, but also to reduce kind of the pain that's currently associated with some of the exams that they face. But I think it just goes to show that we need to kind of expand, I guess, our thinking on awareness and what people, are willing to embrace, and in terms of reproductive health and justice globally.
Great. Well, thank you everybody for sharing. So we're going to go ahead and move into a Q&A portion. So at this time, we welcome anyone to either type your question into the chat. You can also go ahead and just unmute yourself and be the first person to ask a question. And feel free to direct your question to a specific speaker. If not, they'll just take turns answering.
And also just want to add, feel free to use this as a platform to kind of introduce yourselves as well, or treat it more as a discussion, or how this relates to your work, and or if you've been involved in the campaign and things like this.
Hello?
Hi.
You hear me?
Go ahead.
You hear me?
Hi, Rebecca, how are you? Nice to see you.
Fine, thank you. So my name my name is Nimi. My name is Oneko. Nimi, how are you?
I am great. I am great.
Yeah.
When you're done asking your question, I just want to share a quick anecdote after you speak.
Maybe let me just say something. I'm going to be very short, very brief. Well, my name is Olola Oneko. I worked in Tanzania, in Moshi, Kilimanjaro Christian Medical Center, and during that time I met very many people from Duke. And one of these days I was in Duke, and I wanted to see someone whom we can work with in biomedical sciences. And I was told that there's someone called Nimi. So I went to her office, and Nimi didn't know, in fact, what I was looking for there. But I told her that, look, I want to, do you think that we can develop a speculum because many of the women really fear speculum. I think, Nim, you remember that.
Oh, of course. It was very inspirational because I came back and then failed many times until Mercy showed up. But absolutely, I remember that. She's like, can't you just develop a camera without a speculum?
Exactly, yeah. So the development, I think, even of the coloscope, which is now we are talking about, I think, comes from there. So I've been interested, of course, in cervical cancer screening and work for a long time. Well, maybe did I say that I'm a gynecologist obstetrician? I think I did say. And I was also involved in the development of the pocket colposcope and the implementation. The pilot area was in Moshi, Tanzania.
Yeah.
And I think that there was a lot, there's still a lot to be done, because one of the things which I wanted to, in fact, to ask is the coloscope. It does, as far as I can see, it does not, can it, for example, replace a speculum? Because our services, for example, which we do as gynecologists, biopsy taking, cryotherapy, lip, and so on, cannot be done by, I think, using a coloscope. Am I right or not right?
That's right. This is really for screening. The idea is that, majority of women, right? I mean, wouldn't you say of the ones screened, a small percentage have disease that needs to be treated. So certainly you'd have to use a speculum in those instances, but what about the other women that don't? So if you can make the entry into screening less intimidating, that already addresses a big barrier to entry. And the individuals who come in can certainly be educated on follow-up steps and what that entails. But that's after perhaps building a relationship with the provider and understanding more about the disease and et cetera. So I think that's the perspective we're taking.
So Nimi, the process would be, for example, first of all, using the coloscope, and then looking at the cervix, see whether there's a lesion or no lesion. Yeah. Mm-hmm. And then the following, then most of the people is a small percentage, about 12 to 15%, in some areas only 10%, maybe needing the speculum. I think that's the process.
Yeah, exactly. And in many instances, right, maybe not at Moshi, VIA is done at the community center, and then, they're transferred to another site. So there, it could be all coloscope. And if they need to, then they can go, to the next facility to get treatment. So I think anything that can make the barrier to entry low is
exactly.
Okay, yeah. It's really nice to have you on the call.
Which means it is 1 o'clock at night here.
Oh my God, that's what I was thinking. You're really dedicated.
No, so is Massachusetts Center, is that the first place in Africa to use a coloscope? Is it the first one, or there are also some other centers which are now the coloscope is being piloted there?
Yes. So
are there other centers?
Yes.
I see.
Yeah, we've only piloted it in the Greater Accra Regional Hospital.
Mm-hmm.
So we haven't, and based on feedback from there, we are actually optimizing the device, and hopefully soon we'll have it ready for more centers to use.
Can I ask more questions? No. Maybe I'll ask later. I want to know the cost, but I can ask later.
Sure.
Trying to
maybe Mercy, you could communicate with, if you have your email address in the chat, then you and Oneko could communicate, because I think we'd love to collaborate with you.
Yeah, because it is just part of me that I've been doing this thing for such a long time, and I was very happy to hear that some young African lady, yeah, is doing this, and I would be I would be very ready to. At the moment, I'm not in Moshi, but I'm still somehow doing some work there. But I'm now in Kisumu, Maseno School of Medicine, Kenya. Yeah. So, but I would very much like to pilot this telescope.
Absolutely.
I think it's really good. Thank you so much for good work.
Thank you.
Yeah, I'm done.
Great. Thank you so much for your question. Anyone else have any other questions that they would like to share, whether in the chat or go ahead and unmute yourself?
Hello, my name is Chris. Oh, go ahead.
Sorry.
Go ahead.
Okay, so hi. My name is Clau, and well, I work like doing like DIY, do it together and do it with others, kind of gynecology workshops with different groups. Normally like midwives, sex workers, like self-organized feminist, trans hack feminist groups. Either in South America, in Mexico, and I was working also in Europe some time ago when I was living there. Well, I'll tell you that your work is amazing. And I think it's very important because I really think that this kind of like a technology without the speculum, as you said, like to get this entry to start something with this fear that the tool, like the speculum tool make, is very important. So something that I do is normally is like in the workshops, we normally finish the workshops, look in the speculum, look in the cervix. But what we do is put the speculum, each participant put the speculum, and then with a camera, with a webcam, we just project the speculum in a big screen beamer if we have it, or in a computer. So for me, this is very interesting and important. So my question is, how do you have like kind of expansion plan about this tool? No, it's like more, or maybe, of course, for example, with the person I was talking before, you have this maybe collaboration, but how do you think this tool can be like spread, or how can we make these connections to maybe make this, for example, in my case, the workshop that I do, to collect other narratives about how use this tool. Thank you.
Does anyone on the panel want to answer that, or should I? I guess I'll start. We actually are really committed to doing that. I think I said this after the documentary screening that yes, it's important for cervical cancer screening, but I think it's a very important tool for education and empowerment. And when my team was in Peru in March, right before the quarantine, in a community outside of Lima, where women in a underserved community were given it for the first time. There were so many stories and so much excitement around this technology, and they spent a lot of time saying, oh, I'd love this, and I'd love this, and I'd love this about the technology. In fact, they just wanted to see it, improve in certain ways that would make it more accessible. For example, different sizes, different colors. So the idea of collecting stories from different people and from different communities is really something that we're striving to do. And as Mercy said, we're now in the process of designing something that will be ready for broader dissemination. We right now are working with collaborators. In other words, it's a partnership. So I think we welcome you to contact us. There's a number of different ways you can do that. You can contact Alexandria, Ashley, Andrea, and we can or anyone on this panel, I suppose, and we can talk further, because we do really support this idea of, our bodies ourselves and being able to see the cervix and learn more about it. I certainly did when I used the coloscope. So in fact, I think Ashley just put the...
Yeah, I'm just going to throw up a bunch of different ways to get in contact into the chat. So there is no shortage of ways.
Great. And I think Christopher, right, had a question. Maybe.
Well, and I think I just wanted to add quickly to that. So like Nimi said, this initially started off as kind of a cervical cancer project, but over the course of development, we really realized, to get women to use this and even to get people interested, we really needed to target more awareness education approach. And I think people are actually more excited about that education and awareness approach the more we put it out there and about seeing the cervix and talking about the cervix. So we are definitely interested in partnerships for that. And the current telescope is optimized for viewing the cervix, and we are still designing it for actually, being able to see lesions on the cervix, so for clinical use.
Also to add, Clau, I feel like there's so much that our group has to learn from your incredible work as well, with your extensive experience with, having these workshops and all of this. So definitely opportunity for learning from us.
Thank you. Yes, but something that I forgot to say is like sometimes in the workshops, what we do is also like the vinegar test, like the acetic acid test, also to look, but not in a diagnosis way, because it's not. I don't do like diagnosis. What I do is like facilitating in these workshops a space to knowledge ourselves, to see the cervix, and also like to understand that there's other kind of ways, maybe some more close. But thank you so much. I will contact you, and I hope we can get some feedback together. Thank you.
Yeah, and I wrote this in the chat too, but we've got 2 websites now and 2 emails. If you, for example, you're like, oh, I really just wanted to talk to Dr. Hogan, if you reach out through one of these channels, we'll make sure we get you connected to the appropriate person. So for anyone here, go ahead. Any of those channels is a great way to reach any of our panelists today. And now, Christopher, you can go ahead with your question.
Yes, no worries. I was wondering, for any other panelists, I was wondering about the epidemiology of cervical cancer within a temporal spatial analysis. Is there any variance you see within, I know you said African community, but do you see any other variances based on region, based on global proximity to certain regions? Is there any type of epidemic knowledge?
I can start and then others can jump in. So I think, the main driver of cervical cancer is HPV, human papillomavirus. So we see more cervical cancer in regions where there's higher HPV prevalence, but also for people who have trouble clearing HPV. So HPV is super common. Most people have HPV exposure, but our own immune systems kind of clear that HPV over time, and it doesn't lead to cervical cancer. But in certain populations, like for example, in the HIV population, there are the immune system isn't as effective at taking care of HPV. And so that's why we see really high rates of things like cervical cancer, anal cancer, also caused by HPV in the HIV population. So the biggest burden of cervical cancer is outside the United States. It is in global settings. And that's also where we see the majority of death from cervical cancer is in global settings. And so one of the things that I'm involved in is an international clinical trials cooperative group, which is trying to bring cancer clinical trials to settings where they actually see the most cervical cancer. Sometimes we do studies here in the US and we learn from it, of course, but it's not the population that's most affected. And so I think that having a really good idea of where these cancers are the most common is really, really important. The other thing I'll say is the HPV vaccine has changed the epidemiology a little bit, because it actually prevents the development of cervical cancer. So not just HPV, but it actually changes the incidence of cervical cancer. And so where that vaccine has been really well implemented and there's been a lot of uptake of the vaccine, there's lower cervical cancer rates. Like I live in Utah and there's really low acceptance of the HPV vaccine here. And so that's something that several investigators here are working on, is how do we get more people to be interested in taking this vaccine?
Thank you so much.
And another thing I've noticed with epidemiology is when people present. So for instance, in Ghana, I was learning that a lot of people present at very late stages, where a lot of the very easy pre-cancerous treatments are difficult to administer. So if it's cut at an early stage, you can easily just freeze or cut out the cervix. Whereas if it's at a later stage, then you need more expensive approaches like radiotherapies and surgeries, which might not always be available. So I think also because of the awareness issue and the preventative, a difference in preventative care approaches, people tend to present when it's much later and it's really difficult to treat.
Thank you.
So I think we'll have time for one more question if anyone has a question or just a statement you'd like to make at this time.
Hello? Oneko again?
We can hear you.
Okay, you can hear me. I wanted just to know about the costs of a coloscope, the cost.
It's not commercially available yet. So at this time, we don't have a specific price.
Okay.
Cost, I mean, and so I think we'll determine that down the road. But I think our mission is to really make it accessible, both financially,
Yeah, that is very important. Yes.
and culturally. So that's one of our highest priorities. So stay tuned. Keep in touch.
Thank you. I'll keep in. I'll contact you. Thank you. Thank you.
Great.
Well, great. Thank you so much, everyone. Again, if you want to further contact us, there are some ways to get in touch over the chat. The GWHT website is dukegwht.org. So just keep that in mind, and you can interact with us, Facebook, Twitter, YouTube, all of the above, everything. And we are really, really grateful for your presence here today. We're so excited that we got to host this panel event. So I'll let our other panelists and moderators say a quick thank you, but thank you from me for being here today.
Yeah, thank you. This was great. We really appreciate, all of these participants staying on and asking these great questions. Really appreciate it.
Yeah. It was great to talk with all of you, and Andrea, congratulations again on a beautiful documentary. It was really, even though I was a part of it, it just came together so beautifully and was really, really moving. So congratulations.
Thank you so much.
Yeah, thanks to all the organizers of this panel, and congratulations, Andrea. And it's so exciting to see everybody. So thanks so much for coming on today, and really grateful to Mercy for all of the amazing work that you did to bring us together originally.
Right. Thanks,
Okay,
everyone.
thank you all. Thank you.
Thank
Thank you
you.
all.
Bye.
Thank you. Bye-bye.